Welcome, everyone. Today's live thought leader webinar is titled How Upcoming Billing and Coding Changes Influence Healthcare Economics. This webinar is being brought to you by Coker. The live webinar will last 60 minutes, and at the conclusion, there will be an opportunity for Q&A. To submit your questions, simply use the Q&A feature at the bottom of your screen. Now, I will turn the presentation over to our first speaker.
Thank you so much. My name is Alex Kirkland. I'm a vice president with Coker Group. We are thrilled to be with you today, where we will present on how upcoming billing and coding changes influence healthcare economics. And the way that we'll do that is by commenting specifically on the 2023 final Medicare Physician Fee Schedule rule. And we'll go over momentarily what some of our learning objectives and agenda for doing that are. Before we get started, I'd like to give my team a chance to introduce themselves, as we're going to have several speakers throughout the course of this webinar. Beth?
Hi there, welcome everyone. My name's Beth Balcom. I'm a senior associate with the Coker Group. I work on the coding and compliance service line as a physician educator and auditor. I'm excited for what today we're going to talk about and bring the new guidelines into play so you guys can kind of see what that's about. So it's great to be here.
Hi, I'm Brandt Jewell. I'm a senior vice president with Coker. I lead what we call physician services, which is really all things employed physician enterprise or physician enterprise operations, strategy, performance improvement. So we work with this team around both identifying opportunities around the country with different entities and then also implementing solutions and achieving financial performance goals or just operational efficiencies. I'm based out of Nashville and happy to be here today. Thanks.
And as mentioned, my name is Alex Kirkland. I'm a vice president with Coker Group. My focus is related to physician compensation, looking at different productivity models to incentivize, as well as how value-based reimbursement is impacting the changing landscape of healthcare. And over the past several years, we've been very active in this space as we'll talk about in this presentation, Medicare or CMS has implemented several large-scale policy changes as it relates to RVUs that has had a major impact on physician compensation, and has also resulted in challenging survey data. So I enjoy the opportunity of working with medical practices across the country, sort through those types of dynamics. And I'm also located here in Nashville, Tennessee.
Good afternoon, good morning, everyone. My name is Richard Romero, and I'm a senior vice president with Coker Group. And along with Alex and Brandt, I am also located in Nashville, Tennessee. As a senior vice president, I spend most of my time doing general financial consulting, all of which is in healthcare, compensation valuation, business valuation, and expert witness testimony.
Great. With that said, we're going to go into the learning objectives and agenda. I mentioned that we'll talk about these impactful healthcare economics based on the final Medicare Physician Fee Schedule for 2023, what's come out. And what you can expect to take out of today's webinar is that we're going to give you a good overview of the coding and changes and associated compliance considerations to communicate, share with your clients. And then we're going to get into the implications, what these changes may mean from a valuation perspective, as well as operational and financial implications. The way that we'll do this is we'll first just summarize some of the major takeaways from the final rule, and then go take a pretty deep dive into the coding and documentation changes. Beth will walk us through that framework, that updated framework. And then we're going to pull up for a roundtable discussion where we can talk about valuation, physician compensation, operation, some of these implications that I referenced earlier. And we'll conclude by sharing with you some recommended next steps of how to think about talking with your clients about this and what to position in front of them. So before we get into the meat of the presentation and go into the coding framework, I want to just take a moment and just summarize the major themes that we see come across in the final 2023 Medicare Physician Fee Schedule rule. It did come out at the beginning of last week, so it is fresh off the presses. This rule is one of several that the administration has put forth that is advancing this administration's initiative to create a more equitable healthcare system. We do see that play out by pushing on the key themes that they have within their administration of accessibility, quality, affordability, and innovation. The major areas that we see change in, most notably, is going to be around the conversion factor. Within the traditional Medicare Physician Fee Schedule, we do see a 4.5% decrease from 2022. And so it represents a $33.06 conversion factor. The anesthesia fee schedule has a 2023 conversion factor of $20.61, which represents about a 4.4% decrease from 2022. These are shifted slightly from what they announced or proposed in the proposed rule earlier this year, but very much in line and materially the same numbers that they had previously communicated. They did communicate an methodology updates around how they'll update and review the Medicare Economic Index, but those methodology changes are just for review. They are purposefully not implementing them in 2023, as they are deliberately trying to solicit additional feedback and understand a better mechanism to implement that. It's going to, among the major methodology updates, is that they currently practice has been to look at private practice expenses to set some of those practice expense assumptions. This will now be looking at more holistically all practices, and with the amount of physicians that are employed through hospital environments, we'll see more of the economic impact take into account within the Medicare Economic Index. Another reason why they're not implementing this in January 1st, 23 is because there had been previous plans for some geographic adjustments. And so they want to see those GPCI adjustments go through as planned. And so this is just a methodology update that they're communicating on, but it will not go into effect right away. Related to value-based reimbursement, we are seeing some changes there, most notably within the quality payment program and the Medicare Shared Savings Program. As expected, the 5% lump sum advanced alternative payment model payment, that does expire. But to be clear, that expires so that performance year 2023 will not have that, but performance year 22 did have that. And since the payment lags 2 years in arrears, qualifying entities of the advanced alternative payment model for that 5% will continue to receive that through 2024 because the payment lags 2 years, but in the performance year 23, it does expire. And then what we did see is related to the Medicare Shared Savings Program, there is some advanced investment payments for some qualifying ACOs, most notably low volume ACOs that may not have a hospital partner. There are some advanced payments that will be made, but that was just partially adopted as it will not go into effect on 1/1/23, but more so it will go into effect on 1/1/24. These are among several other areas where we are seeing movement in the value-based space, continuing to push us down that avenue. One of the more hot topic items that has been discussed since the proposed rule came out was the split shared visit definition, where they have delayed the substantive portion, that definition that defines the substantive visit. That will now go into effect, the measurement of such, in 2024. 23 will still be based on history, physical exam, medical decision-making, or time. We do still expect that to go through in 2024, where 2023 will be used to measure and assess what that impact is. We'll talk more about that impact as we get into our roundtable discussion. And then the area that I'm going to turn it over to for Beth to walk us through is related to the E&M codes. In 2020, we saw the 21 fee schedule, final fee schedule come out, and it really changed the RVU system, most notably around established outpatient E&M visits. Well, now we're seeing the revised framework continue into fruition, where there's updated guidance related to coding and documentation of hospital inpatient observation services, emergency department, nursing facility, and home services. Beth is going to walk us through a good perspective of what you can expect from a coding and documentation perspective related to that revised framework.
All right, thanks, Alex. So let's just jump right into these 2023 E&M guideline changes. So really the 2023 guidelines, as well as the 2021, they were a collaboration between the AMA and CMS, and they're an extension of those 2021 office outpatient guidelines, like what Alex was saying. The 2021 took effect back in January 1st of 2021. So to help with the preparation for these 2023, I thought it'd be good just to kind of give a general review. The guidelines really are to help promote patients over paperwork and really simplify that provider documentation requirements. These new 2023, like Alex said, will extend over the remainder of our E&M code sets, which includes our areas of observation, inpatient, emergency department, our nursing facility, and home services. These will take effect January 1st, it's really right around the corner. So my focus, is really just going to be on these 2023. As I mentioned, it's just going to be a general overview. We're not going to do a thorough deep dive into the guidelines, but I just wanted to provide just a general overview of what they look like. So if you're familiar with the 2021 guidelines, really this should be a smooth transition. But if you're new, I'm hoping that this will help at least provide a little bit better understanding of what the guidelines look like and how they're supported. So just like our 2021 guidelines, our 2023 will no longer use our history and exam towards that code level or that decision making. Providers are still going to want to perform and document what they feel is medically appropriate for the history and exam and things like that, but that's really not what's going to be driving the level of the code. So in addition to our office and outpatient codes, all of the non-emergency department E&M levels, like our observation and inpatient, will be based strictly on medical decision-making or time. So as I mentioned, this means history, review of systems, and exam will no longer count towards the code level, and it's really going to be based on what the provider feels is medically appropriate. For our emergency department, this is strictly just going to be based on medical decision-making and not the option of time. Again, that's all about what the provider feels is medically appropriate for that history, review of systems, and exam. So with the 2023 guidelines, there are new prolonged service care codes that were created by AMA as well as CMS. They also created new times associated with these E&M codes. And the AMA has a limited and done a big revision on many of the E&M codes. So to provide a good overview of where these changes, these revisions are taking place, I really wanted to point out some big areas that are being deleted. Our observation codes will be done as of January 1st, and they're now going to fall under our inpatient codes. Inpatient codes have now been revised to be described as hospital observation and inpatient. Another area of deletion is our domiciliary and rest home codes. Our custodial care codes have been deleted as well. Those will now fall under the home and resident services. I briefly mentioned our prolonged codes. CMS just released these new G codes that will represent prolonged codes. So depending on where the service is taking place, whether it's inpatient, ER, residents, there's a specific code that CMS has created for those prolonged codes. All right, so let's look at our first option with these 2023 guidelines. So the first option that providers will have when choosing that level of service can be based on time. With the 2023 guidelines, time is really not an option for our emergency department. The AMA stated it's because the emergency department really is provided on a variable intensity basis where they're seeing multiple patients, they have multiple encounters going on. So time is really hard to suffice that time in the emergency department. All of our other E&M codes, though, time can now count for work that the provider performs on the day of the encounter. This can include items that are face-to-face, non-face-to-face items, but it does have to be what the provider is performing directly, him or herself. With the changes, I'm not sure if some of you are familiar, but with the changes, that verbiage of 50% counseling and coordination of care is no longer a requirement. It really is about the overall time that the provider has spent on the day of the encounter. This means it doesn't really need to be broken down minute by each task that the provider is doing, but we do want to see that overall time that the provider is spending with various tasks. An example documentation piece that I like to use for our time elements are a total of 50 minutes was spent on this visit reviewing previous notes, counseling the patient, ordering tests, adjusting medications, and so on. So what activities can count towards time? So as I previously mentioned, it's really no longer about that 50% counseling rule. It's now about what activities that the provider performed on the day of visit. So a few items that can count from this list that can count towards the time is maybe preparing to see the patient, reviewing tests, chart notes, maybe performing a pretty extensive medically appropriate history and exam. All of those can count towards time. Maybe our provider is independently interpreting results and then talking with the patient and the family about what those results look like. All of that can really total up that time. So, you know, this is really more favorable for our providers because before it was again about that 50% rule. Now it's really about the work that the provider is doing throughout the day. So I think these guidelines are helpful on the time aspect. So items that cannot count towards time, that would be travel time to and from facilities or maybe to the patient's home, their staff time, whether it's clinical staff or the front office staff. And then I always like to bring up those non-medical discussions that providers sometimes have. How is the family doing? You know, unfortunately, that's not part of the medical care, so that can't count towards the time. And then going back to our documentation piece, you know, compliance for the documentation of time is really important, especially with these new guidelines. You know, we want to accurately reflect the tasks that the provider is performing on the day of that encounter, and we want to see the total time that they've spent throughout the day on these different tests. CMS has recognized that terms like greater than and more than should not be used, and they're not going to consider that as time elements when reviewing chart notes. And then lastly, with our time, we want to remember medical necessity when using time to support the E&M level. We always want to ask, would it be medically appropriate to use time on a particular case? An auditor may question why it took 15 minutes to review a complete blood count without any additional details in the note. So providers do want to be mindful with their documentation. They also want to be mindful on the total time that they spent for the day. Does the total time documented seeing patients exceed the number of hours provided in a workday? That is a red flag for carriers and auditors. So we just really want to be mindful when we're, using time. Okay, moving on to our second option, which is the medical decision making. So this is the second option that providers will have when choosing that level of service. So what is medical decision making? Medical decision making really is what it takes to determine how to take care of the patient. So with the 2023 guidelines, medical decision making can include establishing that diagnosis, assessing the status of the condition of the presenting problem, and then coming up with that management option for the patient. Medical decision making with the guidelines is now defined by 3 elements. And within those 3 elements, the first element is the number and complexity of problems that the provider is addressing. Moving on to our second element within our medical decision making, that's our data section. So data that the provider has reviewed and analyzed in order to determine how to manage and treat the patient for their presenting problem. And then our third and final element is our risk. This risk is going to be based on the management decision that the provider's made that's associated with the problem. When we look at our medical decision-making table, we have these 3 elements. The guidelines state we have to meet 2 of these 3 elements to support that E&M code that's going to be billed. All right, and then this is our medical decision-making table. So when the 2021 guidelines came out, the AMA created this table really breaking down those 3 elements. They've now redefined CPT codes and how they are categorized. So the medical decision-making table is broken down into 4 levels. We have straightforward, low, moderate, and high. And our problems addressed, our data section, and our risks associated with the management plan are then placed within these levels to determine what the appropriate E&M level is. As you can see on this table, that problems addressed and managed are classified as terms like acute and chronic. So previous guidelines and our current guidelines for hospital, it's all about new and established. Now it's really about the complexity of the presenting problem. Is it acute? Is it chronic? Is it something that's self-limiting? So that's a big change that we've seen with these guidelines. Okay, a few items that have changed on the table with the 2023 are terms that we're going to see verbiage like requiring hospital, escalation of hospital care. These terms were created to help align our hospital inpatient observation and ER codes so we can now utilize them to match up with the guidelines. I have gone ahead and highlighted these changes in yellow, so you'll see this throughout the grid. So if we just break down one of these as just an example of how we can come up to, for example, a low level of medical decision making, you can see in the low level, the provider would need to address at least one uncomplicated illness or injury that requires hospitalization. Then in the data section, they would have to maybe review external notes, maybe order some blood work. And then our risk column would be the management plan that the provider came up with. Any of those would support a low level E&M code. Again, as a reminder, we only need to meet 2 of those 3 elements. It doesn't have to be all 3 at the same level across the board. Okay, moving on to our moderate level. So this is, we'll pull out an example of this, a problem such as a chronic illness with exacerbation, and then maybe an order and review of 3 unique tests. And then we have our prescription management for our risk management would all support a moderate level if we're meeting 2 of those 3 elements. And then our high level, again, I highlighted some new verbiage that the 2023 guidelines are now reflecting. And again, it's talking about the hospitalization. So an example of a high level would be maybe an acute illness that poses a threat to life. The provider maybe did an extensive amount of data performed, and then the decision of escalation of hospital care. Any of those meeting 2 of the 3 elements would support that high level. All right, so let's bring it all together. So with the revision of the E&M codes for our 2023 guidelines, they're now defined as straightforward, low, moderate, or high. Apart from our emergency department codes, time for some have also shifted with these 2023 guidelines. And we did provide in times in the appendix section of the presentation, so you can find that information there. So just for an example, if we look at our observation inpatient initial code 99222, you can see that a moderate level would have to be met on that medical decision making or 55 minutes to support that 99222. Okay, whoops. Okay, and here's our consultation codes, whether it's office or outpatient, or the observation or inpatient. Those all have new descriptors, either the straightforward, low, or moderate, and then the new times associated with them. And then here's our nursing care facility, our domiciliary rest home, custodial care, and so on. So these are all the new descriptions with the times associated with them. So let's talk about our documentation. This is the area that's really been the most important, is going to be the most important with these changes. So we know documentation's always been important with compliance, patient care and whatnot. But with the existing 2021 and these upcoming changes, thorough documentation is going to be very important. Remember, we have providers out there that's going to be brand new to this, our hospitalists, our ERs. They haven't been on those 2021, so they're not aware of what the guidelines, what the documentation is going to need to look like. We really want to start having conversations about that. So I can say during some audit reviews with the 2021 guidelines, we commonly found a lack of documentation in multiple areas. So some of the areas that we found during our audits was lack of understanding what the complexity of the problem was, or even what the management plan was. We also found commonly vague verbiage for time. It really didn't provide that thorough, what were the tasks that they were doing during the treatment. Some other areas that we would like to see improvement on with the 2021 and the 2023 guidelines is continue documenting that history of present illness, a detail of the acute events, statuses of chronic problems. Those really are a must. Because now we're looking at what is the complexity of the problem. And so we want to be able to distinguish how complex the problem is in the notes. Also, a history and exam that may support that medical necessity of the time during the visit. So that's important to see in the documentation as well. Another area of improvement that we would like to see is the documentation and clear assessment and a plan for the problems that are being addressed. We want to see what that plan is for the patient. Just simply listing a list of diagnoses that the doctor discussed that day really does not suffice to support that level of service. We want to see the management plan. We want to know what elements are being hit. And then lastly, documentation should clearly indicate tests that the provider ordered and reviewed on the day of the encounter. So defaulting or pulling results right into a note without any correlation is hard to determine how it's associated with that visit for the day. So we want to emphasize, doctors really need to correlate the information being pulled in and how it's relevant to that visit for the day they're seeing the patient. Documentation should also clearly reflect the review of outside records when that takes place, or even if they're having to get that information from an independent historian. We want to see who they're having to talk to get more information on the patient. And then finally, if using time, that clear documentation of total time spent along with each task performed is a must. Really insurance companies have been and will be continuing to look at that documentation because time is such a broader element now. So, well, I think that's a good overview. I know it's a lot of information, but I do hope it's helped bring some clarity to the guidelines. But I'll go ahead and hand it over to Richard.
Good afternoon, everyone, once again. So obviously Beth is highly experienced on these issues. And so as we try to take a look at what does this mean for us, we're going to address this from a couple of different scenarios. I'm going to tackle, to start with, fair market value. Brandt's going to get into some reimbursement and operations pieces, and Alex is going to really focus in on some of the comp plan and compensation plan design issues. But as we think about all of these pieces, we've got billing, coding, fair market value, IT, operations, the comp plans. That's on top of, quite frankly, a number of changes that we have gone through most recently that, the laundry list and that we've all experienced, the update to Stark, AKS, clear commentary about relying on a given percentile to validate FMV, the previous code changes that Beth was referring to, pandemic, inflation and workforce shortages, and then quite frankly, I think a reliance and in a lot of ways an over-reliance historically on survey data. We know that a significant number of industry participants, as we know them today, still have not adopted those previous code changes, and yet here's another rung that are coming down the pike. Alex is going to talk a little bit more about that shortly. But as we think about the impacts on fair market value, I think it's important to consider those changes. There's time. We've got some work review changes and what that might mean as you're assessing fair market value. So especially if we're looking at this from the inpatient side, we've got a change in codes. As we put together, for example, common application might be on a stipend type scenario. What is the staffing that's required for this level of service? One of the cross checks that we might often use is what's the expected time for that? Well, as Beth mentioned on the emergency side, that's a key piece because of all of the different patients that they may be dealing at in a certain way. If we're looking at hospitalists or quite frankly anesthesia, which is I think it's its own world right now given the dynamics in that space, I think one of the takeaways as you're moving forward with these changes, the assumptions of those valuations that were in place that your clients may have in place, analyzing those to say, okay, with these code changes, are there the possibilities for significant shifts? Reduction in staffing if folks are going to be able to be more efficient. So I would say a key takeaway would be make sure that what's in place still remains and is still appropriate. I think when we think about fair market value, and I always like to give people some high level takeaways because it can get very complex, but in some ways it's also very, very consistent. When we're looking at fair market value, we're looking at both the provider as well as the indirect and direct support cost for them. And when we're thinking about compensation, at least on the provider side, I tend to look at that as time, effort, and outcomes as we think about what the work RVU value, the time, the correlation, and the changes that Beth went through, and obviously the outcomes with regard to value-based reimbursement. As we've all known, and it's becoming increasingly more discussed, the survey data is not a definitive means in and of itself to determine fair market value. It's a starting point. And I think about that because one of the big takeaways that I think is important as we're dealing with these changes, because in some ways, these changes are not so significant or different, but in other ways they are, and not sound duplicitous there. But as from a valuation perspective, we always have new code changes. We always have changes with regard to conversion factors that we're looking at. So we need to remember that valuation is always a forward-looking concept of what's going to occur in the future, but it's also very much based on a factor of comparison. And so we've got what we think is a known, comparing that to a subject circumstance to determine that conclusion. Well, we know that survey data, and not to beat up survey data, it serves its purpose. We still use it every day in this business, but there are changes. These changes are not going to be reflected. So that's a reminder. And so we need to think about the facts and circumstances that are underlying those historical trends and how that compares to our subject agreement. That includes the agreement itself, the circumstances and services around that, and around those parties. So if we think about the importance of those facts and circumstances, I think more discussion should take place with you and your clients, and quite frankly, the evaluators that you're using, to make sure that you're appropriately accounting for those and how those are going to change and how that's accounted for in those valuations. I think just briefly, those are some key points that I wanted to make about the FMV side. And as we talked about, there's a number of other areas that these are going to impact, reimbursement operations, and then obviously compensation plan design, which Alex is going to speak about next.
Thanks, Richard. When we think about provider compensation design, I think that it always seemingly needs to go back to, well, how much money do we have to fund provider compensation? One of the major effects that we're seeing from this final rule that's come out was another cut to the Medicare Physician Fee Schedule's conversion factor. And so while there will be some shifting RVUs and new higher values in some other care settings that will offset some of these reimbursement amount, or some of the reimbursement cuts, we are going to see a cut in reimbursement to some positions. And so how are you going to fund additional compensation considerations with that in mind? And I think that it's purely speculative to say this, but just something to consider is that at the end of 2020, as the 21 final fee schedule came out, what we saw was an 11th hour Hail Mary from Congress that gave some relief to the conversion factor. There are murmurs that there could be some relief made to these conversion factor cut, but that's purely speculative. But if we do go back into history and remember how the SGR got fixed every year with the doc fix, and at the 11th hour, Congress suspended scheduled cuts. There is reason to believe that some of those cuts may be mitigated before the end of the year. Again, that's just speculative. And so making sure that you have your compensation up to date to reflect what may come through is just a prudent way to think about this and how to position things with your clients. And so one of the things that we recommend is to model the work RVU impact and what the reimbursement impact of these changes are as well. 2021 Medicare Physician Fee Schedule saw the major shift of work RVUs in the outpatient E&M setting But there are going to be some shifting work RVU values and changing work RVU values in this setting as well. And so they're not as impactful for physicians that are achieving those work RVUs. It may not make up a large bolus of their work RVUs. It certainly can for some, but it is just a reminder that we need to be aware of what is the utilization of the provider and how do we need to monetize and reward that utilization in consideration of how these non-monetary RVU values have changed. So we work with organizations to try to quantify that and to think about how utilization patterns are shifting versus RVU values are shifting as well. To complicate matters, survey data has not caught up to the new Medicare Physician Fee Schedule changes. And so it's very difficult to do this without some updated guidance or updated survey data. Our guidance has been to utilize a data set that makes sense, that there is strong integrity into that, do a detailed CPT review to understand what these policy changes mean from an RVU perspective, both before the policy changes and after the policy changes, so that you can identify and isolate the impact of changing RVU values. Richard mentioned that there are a number of organizations that have not yet adopted the new RVU values, the 21 RVU values. They've stayed frozen on the 2020 MPFS. That may be as many as 20 to 50% of organizations, as we hear from industry sources. I think that we're going to see more and more organizations move towards these new fee schedule changes, and so they have to figure out how to implement these new RVU values. One major reason why they're going to be moving towards these new RVU values is because there's new codes that are being recognized and there's deletion of other codes, as Beth had mentioned to us. And so it becomes more problematic on administering a compensation plan that's tied to RVUs if there's no longer an RVU associated with a code that's you're not getting reimbursed for from Medicare. Or if there's a new service and because a new CPT code that has a work RVU value, but you're not set up to credit the provider with that new work RVU, it's becoming more and more difficult to stay frozen on the older 2020 MPFS. And so I think we're going to still see organizations move towards the new RVU values. And to do that, because the survey data is so unreliable, there needs to be an intentional way of implementing those new RVUs. We've worked with organizations to revalue the rates per work RVU and associated work RVU thresholds, so that as these changing impacts of new shifting RVU values are coming into fruition, that's going to mean something different for a 50th percentile or whatever the hurdle is from a work RVU threshold perspective. And so we've done a lot of work with organizations, and it would be prudent to continue thinking about that. Organizations that have gotten in trouble are ones that have implemented the new RVU values without revaluing their rates per work RVU. And what they're having to do is unwind those changes of flowing through the new MPFS because they can't afford to pay out this extra bolus of work RVUs when the reimbursement did not materially shift. A couple final points related to physician compensation, and that's one of them is around value-based reimbursement. We see continued push towards this. I think that, regardless of the party of power, there is pervasive thought that the only way we're going to be able to bend the cost curve from how much we're spending on healthcare expenditures is to shift from volume to value and to make that risk more appetizing to providers. And by doing things like the advanced payment for some ACOs and in other initiatives that are pushed through the quality payment program, we are seeing the continued push towards value-based reimbursement. And so how do you have a foot in both canoes if you have an organization that is still predominantly fee-for-service, but is now having some of the revenue streams augmented with these value-based reimbursement plans? Our recommendation has been to view those reimbursement streams as an all-encompassing reimbursement bolus of dollars, and use that total revenue to inform how you want to incentivize physicians. And within that compensation plan, having some level of value-based incentives geared within that would be appropriate. Because of the large-scale coding and documentation changes that have taken place, we've often worked with organizations on a crawl, walk, run perspective as they think about those implementing value-based quality metrics. And from a crawl perspective, it may make sense to have citizenship, patient access, as well as some coding or documentation goals, those process type metrics. And over time, you move more towards outcomes-based metrics that are aligned with MIPS reimbursement or how other payers are reimbursing in nature. I know Brandt's going to talk more about the operational impact of this, what you can consider from a revenue cycle perspective and other considerations. So Brandt, let me turn it over to you, and you can kind of walk us through what our recommended next steps are as well.
Thanks, Alex. Yeah, I think we've covered a lot here. Don't want to overwhelm, but I think from an operational perspective, my first thought is that we have to understand the impact, both functionally and then financially across the board. So Alex was touching on that specifically related to compensation. Richard mentioned it as well. But as we think about the impact on revenue cycle and how we could avert any type of drop in reimbursement as a result of some of the confusion that goes on with these types of changes. Long term, I think a lot of organizations will get there, but in the near term, there's some pretty quick analyses just to estimate the financial impact on revenue and collections that should be expected, and then to address it both from a physician compensation design, staffing, and workflows in both the clinic setting and in the billing office. And so as you talk with your clients and you think about how they prepare for this, I think one of the first steps would just be kind of a financial review of how is this going to change our operating reality based on what we did last year or the last 2 years, whatever it makes sense. And then starting to think about kind of the functional rollout. We talked about the training, and I know from an operational perspective that sometimes gets overlooked as, sending out an email or making sure the providers were, got a notice about the changes. But some of the changes that Beth walked through are very fundamental to care delivery. And it's going to take some providers either a lot of time or maybe too much time, never type timeframes, to get some of these things right and to change that behavior. Behavior change is the hardest thing we deal with from an implementation perspective. And so starting every organization does this differently. And so it's not a silver bullet when it comes to training, but there needs to be some consistent feedback and education for providers, for staff, coding, billing staff, and clinical staff as well. And then being able to follow that through and audit that and make sure that things have continued to stick. Looking at the templates and both their visit templates and their documentation templates, and making sure that those support these new coding guidelines and that everything is up to date. A lot of organizations are woefully behind with just keeping up with making sure their system is current on all these types of things. And so especially if you have different templates and provider preferences throughout the organization, then it can become pretty unwieldy to manage, and then specifically to audit thereafter. One of the things as it relates to care delivery that we haven't talked a lot about is how this could impact the utilization of APPs. We get that question a lot as we work with clients. We know we need to leverage APPs to some degree, but we don't want to do it too much. What's our strategy with APPs? And then how do we hire and build the infrastructure we need to support it? And so again, here we're talking about some fundamental care delivery differences that are going to directly affect reimbursement. And so keeping current state, even if you have a defined APP strategy, may not be viable moving forward. And so I think you have to look back and question as you do that initial financial analysis. Now you have to say, okay, well, if we do it in current state, it looks like this financially for us. But what if we change the way we handle and utilize our APPs and the way we structure these visits, and the relationship those APPs have with the staff, and how we do intake, thinking about patient intake and HPI and all those things will be pretty critical to making this work. And so with any change like this, it's new rules to the game that we've been playing for years and years. And now we have to figure out how we change to be successful under the new paradigm. And for that, I think, you know, a lot of what Alex and Richard and Beth have articulated are sort of the fundamentals of the new rules and how we need to be making the changes, but then getting the behavior to adjust at the front lines of your organizations is the hard part. And so part of that's evaluation, part of it is the training and kind of the implementation piece, and then the accountability is the third leg of that stool, where we have to have a system for following through and making sure that we can spot the lack of adherence or those that are struggling to keep up with new guidelines. You know, the revenue piece and coding, I think we'll often do kind of coding and documentation and billing audits for clients, where we say, let's make sure this was coded and documented correctly per the new guidelines or just in general. And then let's follow that claim all the way through payment or denial, if that's what happens. And so, you know, doing some sample audits like that can really be insightful. You don't have to do a high number of them to figure out if things are working well or not. You can do it by individual provider. And so there are a lot of tactics that could be deployed, and you know, figuring out what would be the best for your clients and the organizations and provider entities you're working with, I think is paramount, and they all do it a little bit differently in my experience. So as we've tried to summarize here on these recommended next steps, and then we'd love to take any questions that are out there. You know, having that coding communication plan, I think we've talked about that, making sure that you have not just communicated the information and said, hey, everyone just be aware of this, but having specific tools and checklists. And Beth develops things like that for clients, where it's just a one pager that sits next to them at their desk so that they can be reminded and ingrain this into their daily workflow. And it takes time, you know, for people who have another ingrained workflow to make that change. So I think the more you can do to actually develop tools and not just to blast out emails or post flyers in the break room type stuff, you'll see more impact and stickiness with those tactics. The evaluation of the HR and scheduling templates, again, this is very different by system and by client, but as you start to mess with templates, you really are affecting almost every area of clinic operations. And so understanding the impact of, well, if we're going to make this adjustment, who needs to know that? And that could relate to patient intake, it could relate to patient scheduling, it could relate to follow through and billing and all the things that go into you know, a successful completed visit and being paid accordingly for that completed visit. And as you start to touch things, there's a waterfall effect to all those different areas. And so I think it's important to understand who's going to be impacted and then have a defined plan for everyone. So, you know, communication. I think Alex did a great job covering the provider compensation impact. Modeling that out is pretty straightforward. That's one of the better and I'll say easier financial exercises you can do. But if you're paying based on work RVUs, this is something that has to come to your mind. And then as you look at the outcomes of those financial analyses, then you can start to think about things like APP utilization, how we support staffing for that, how we funnel patients through our organization, how we manage patient access as an outcome and as a means to that provider compensation. So I think compensation is a great place to start because it's often one of the larger expense items, and it also is directly tied to your revenue and productivity of those providers. And then lastly, I think, as I just mentioned, conducting some type of revenue cycle and compliance review where you're doing some of that coding and claim auditing and following through to make sure that you're getting the results that you have implemented and that nothing's falling through the cracks. And often these things, we say the right stuff at the beginning, and then if we don't follow through with accountability, then nothing sticks and we don't get the changes that we're looking for. And if you do that financial analysis on the front end, you'll have some financial targets. You should know what you're working towards, as opposed to just hoping everyone comes through and complies. I know we've got about 10 minutes left, and I believe I'm going to have the AHLA team, maybe Kristen, qualified. I think I was looking in the right place. I have not seen any questions come through in the chat, but I believe the process is if you want to ask a question, then please post it in the chat, and then we'll try to sort out who's best to respond here. It looks like no questions yet. So we'll give everyone a minute here, and If there are no questions, then we'll give everyone some time back. But we certainly appreciate the time today and appreciate you joining. If you have questions on these things, I know we kind of ran through all of this, but you can get our contact information directly from the slides and or from Kristen and the HLA team. So don't see anything coming through. But we'll hang on here for just a minute. And then Kristen, I'll let you cut us off when you're ready.
As we wait for questions, Richard, I wonder if you wouldn't mind commenting on, we talked about a number of organizations that are still on the old 2020 NPFS. I know that you've been a part of some industry organizations that have quoted numbers and have had some sense of how many are on the old versus the new. Do you mind just adding a little bit more clarity or context around that?
Yeah, thanks, Alex. So there is an organization called the American Association of Provider Compensation Professionals, and it's a nonprofit that is really targeted for all of those that are dealing with provider compensation in some form or fashion. These are typically folks in systems that are dealing with these issues. And so they ran a series of basically informal surveys amongst their members, those different systems, and probably 70 to 80 systems, based on the last go around, somewhere between, I think it was 25% of respondents did not even plan to implement any coding changes or the new MPFS changes until 2023, as it comes to with regard to work RVUs. In hindsight, I don't know if that was to make sure they capture both sets. Now that we're dealing with outpatient, there was another, I think, 33% that was planning on doing it this year. So that's an annual question that they ask. So I'm interested to see what the results will be going forward. But clearly, I think one of the other things to consider, and for those that are advising clients, something interesting that came out of that survey is that some participants had indicated that they would have liked to implement that. And this really relates to a technology issue that they are essentially using what I call a host hospital's EHR system. And so they can't independently make those changes. They have to do it when the host hospital decides to implement those work RVUs. So in some of those rural hospitals, kind of a unique dynamic to think about. So one of those things we may not inherently automatically think about. So as you're looking at those, not only implementing, but is it possible to implement for clients, I think is an important consideration. So
thanks for that added detail, Richard. And we recognize that there may not be any questions right now, but as you think about things, we'd love to hear from you. As Beth has presented right now on the screen, you can see our contact information. Please feel free to take it down, shoot us a note. We'd be happy to engage further and talk about any offline activity that may be of interest. But with that said, we certainly appreciate your time today, and thank you for being with us as we've gone through this material.
This concludes today's program. Thank you all again for joining. Thank you again to our speakers and to Coker Group for presenting this webinar. The live webinar will be disconnected now.